Okay, good afternoon, everyone. Welcome to November's governing body of NHS Sheffield CCG in public, which we're live streaming this month. So I will start with our apologies for absence. So there are no apologies from absence this month from any voting members. Members in attendance, we've had apologies sent through from Sheffield LMC. We're also noting that John McElwraith will be joining us briefly during the meeting and leaving early. And beyond that, we are all here. So I can confirm that the meeting is quorate and we are good to go ahead. And I'll just cross-check that with Kath, please. Yes, thank you. Okay, so we'll start with declarations of interest. Does anybody have any declarations of interest in any of the items on today's agenda that they'd like to declare now? No. Okay, thank you. Perfect. Kath, have we had any questions come through from the public?
No, we've not had any.
No questions from the public, thank you. So I'm going to take us over to approval of the minutes of the previous meeting. So I'll take these page by page, and if you could raise your hand and notify if there are any changes or amendments that need to be made to the minutes, which are from the 2nd of September 2021. So we'll start with pages 1 and 2, 3 and 4, pages 5 and 6, pages 7 and 8, pages 9 and 10, pages 11 and 12, page 13 and 14, pages 15 and 16, pages 17 and 18, page 19 and 20, page 21, and finally page 22. Okay, so I've not been shown any changes to any of those notes, so we will accept them as a true record of the last governing body meeting. Okay, and now turn our attention to the matters arising from the public minutes here. So the first question, the first matter was a question from the public, item 122/19. Looking at the minutes, we will be pausing that work for the time being and bringing an update in the near future. So if we could just ask Brian if there's any further update on that matter, please.
So there's no further update at the minute, Chair. I'll keep the action ongoing and take it into the Accountable Care Partnership Workforce Group.
Thank you, Brian. Item 36/21 has been recommended for closure. Item 50/21. This is an item around scheduling the Better Care Fund going forwards as an agenda item. Jackie, could I ask for an update on that item, please?
Yeah, so that's part of the agenda for next time's development session in December.
Okay, thank you. So item 82 and 86 have been recommended for closure. Item 97 has been recommended for closure. Item 98, we are expecting to receive an update today from the EPRR matter. Jackie, have we got any update? Your name is next to that, so is there any further update for that one?
Yeah, so we've got confirmation from Sheffield Children's and Sheffield Health and Social Care Trust that they submitted returns showing substantial compliance. STH have said they don't want to share until they get formal response back from NHS England, so I can't confirm what they submitted.
Okay, thank you. Linked to that is an action for me to pick up a discussion with Greg about how that fits in to the wider EPR actions across the regional footprint. I've not had an opportunity to catch up with Greg about that yet, but we will provide an update in due course. Item 99, the two parts there have been recommended for closure. Item 100 is recommended for closure. Item 101, which is an item for me to pick up a discussion with a wider system around pressures, particularly with the finance report. An update will come in private to governing body for that matter. Item 101, we have month 4 performance and delivery report. The item there was to ascertain if the Director of Public Health would be attending the November governing body, and to ask Director of Public Health to provide us with some information on care homes at this stage. Greg, you are with us today at governing body, and a note that the item itself suggests that we'll be having an update today. Can I confirm that will be the case, or is that something you'll bring at a later stage?
No, I can do that now or at a suitable time on the agenda, Terry. Have some good data in front of me now.
Do you want to do that item now, because we've not got it on as a formal agenda item? So yes, please.
So briefly, in terms of COVID vaccination, we've got 95% coverage for care home residents, with 44% of them having had care home residents having had a booster. Care home staff, we're on 90%. Being fully vaccinated, both of these dose to 90% booster, and Domicare staff are 79% fully vaccinated, with 7% having had a booster. Difficult to know actually what we could do that we aren't doing to get coverage high, but it's worth bearing in mind that coverage, certainly for staff vaccination, is of a number we could only dream of when comparing this to usual coverage for seasonal flu vaccination. We continue to try and get coverage a little bit higher than it is, but 90% coverage in staff is pretty good. And of note, it is now obviously mandatory, and that will cause us some workforce pressures as people may choose to leave the profession, and that will be a problem. But all up, we continue to support the sector, and the sector has done an amazing job getting coverage as high as it is.
Okay, thank you, Greg, for that update. And we have two final items on the matters arising. 103 and 104 have been formally recommended for closure. Okay, I'll turn us now to item 7 on the agenda, which is we usually have a patient story as part of the opening section of governing body. And this month we are looking at the story from the perspective of primary care. So I'm going to hand over to our medical director, Zach Mcmurray, to introduce this item, please.
Thanks, Terry. I'm going to break a habit of a lifetime and probably not say anything, because I think this video is self-explanatory. As you said, you know, this is frontline staff working within one of our most deprived parts of Sheffield. And I think it's probably best just to hear the story, and then we can maybe comment afterwards.
Okay, thank you, Zach.
I can't hear the volume.
No,
I can't.
Coming in and you're putting in a 10, 11, 12 hour day.
Can people not hear that? Can they?
Just picked up some sound there, Lucy. So if you could rewind it to the beginning, and we'll try again.
I'll turn my volume right up. I don't know if it's mine or yours. Okay.
We get trained, we're being busy, and we don't want to see people, and I like seeing people. I became a doctor to see people. I didn't become a doctor to work in a call centre. There's a lot of discussion at the moment about how much we're doing remotely and whether we should be seeing more people face to face, and that's very wearying actually in the background. You know, when you know that you're coming in and you're putting in a 10, 11, 12-hour day, working as hard as you can, and then to go home and see newspaper comments that essentially say we're not doing anything and we're lazy, and that's very soul destroying.
It's frozen on my screen. I don't know if it's frozen everybody else.
I'm not getting the video.
We're just getting the sound, Lucy.
There's just this absolutely unmeetable demand now. But there's also, you know, maybe 200 prescriptions, 50 to 100 letters, tasks, emails now. You know, so there's all these different results. So there's all these different streams of admin, and that represents hours of work every day as well that has to be covered.
Every day, every single slot will be filled, and there'll be demand for more. And I think my colleagues on reception in many ways have a terrible time of it because they get the angry patients every day. So for example, this morning, there was someone yelling and threatening us, you know, even before we'd come, you know, into the surgery.
There's a narrative that what we do is simple and not complicated. It's just so demoralizing at the moment. Where do you start? It's the job is so hard, and to have that, it's just utterly demoralizing.
People may well leave because of stress with work, and we're seeing GPs and managers leave fairly regularly, you know, throughout the country, which is really sad because everyone's trying to do their best.
The government promised us 5,000 new GPs, and in fact, there are 1,300 less, I think, at the moment. I have never worked as hard in 20 years as I have in the last 12 months. And days when you know that you just have to keep going, but you just wonder how you're going to get up the next day and carry on.
All we are is human beings who have years and years of experience seeing thousands and thousands of patients, and we can put that to good use. But we are human beings, we're not machines, we are not robots, and neither are patients.
And actually, were general practice primary care to fail, the whole NHS would come crumbling down really fast.
Advertising on YouTube helps me reach engaged.
Thank you.
Okay, thank you, Lucy, for sharing the video. I'll open that up to comments and questions from governing body, please. But before I do that, Zach, is there anything that you wanted to contribute first?
Yeah, I think it's a shame that the quality of the video wasn't better, but I think we got the gist of it. I mean, I've been a GP for 30 years. I really just don't get it at the moment. I don't get what the negative publicity is about. I'm never going to defend the whole of general practice, but you know, to demonize the whole of a profession, I just find totally unacceptable. And the effect on morale when we come into the worst winter in the history of the NHS could be absolutely devastating for the whole system, possibly terminal for the whole system. So we need to understand it. You know, I guess people have seen that video. You know, is that just lazy frontline staff that need beating with a big stick to make them work harder? Or is there maybe a little bit something that's a bit more fundamental and maybe an adult conversation that we have to have around capacity, supply, demand, and the NHS model? And I think it's that. And I think there's also a conversation about society. You know, what are we becoming as a society with the levels of abuse that seem to be just accepted as normal now? It isn't normal, it's not acceptable. So, yeah, nothing much more than that to say. I mean, I'd be really interested to hear and comment. I do want to make it clear, you know, I won't defend the whole of general practice. You know, just so that there are some GPs and practices that perhaps don't perform as they should is very similar to there are some politicians who perhaps are corrupt. There are some newspaper editors who probably have tapped phones in their time. But to label everyone as the same, it is just totally demoralizing at a time that, as Greg says, general practice has delivered 75% of the COVID vaccines and has probably got us to the point that we're beginning to get out of the COVID hell. So I really just don't understand it. I don't know where we're heading with this. I've never seen morale as low as it is at the moment. And it's like they said on the video, if general practice fails, the NHS fails. And we've just really got to try and keep it together. So I think that's all I've got to say, but just interesting to hear other views.
Thank you, Zach. Paul, could I bring you in first, please?
Terry, yeah, I've worked at Dovercourt Surgery for, 26 years. And like others and other comments that's been made, I've never worked as hard as we have done for the last 18 months. And it's relentless at the moment. But as Zach said, the abuse that staff are getting is not warranted. It's unacceptable. Myself and Shell got an email yesterday from a manager from a practice not far from us, part of our network. I have never seen the content like it ever. The abuse, racial abuse, the swear words what were in the email. If I said half of what were in that email at Barnsley at the football match on Saturday, I'd get locked up. That's a fact. It's not acceptable, Zach. But the problem is it doesn't seem to be getting any better. And that's the more worrying things. I thought it might have eased off now, but I've just been talking to our staff this afternoon at lunchtime. It's not getting any better.
Okay, Amir, please.
Right. Where does one start? I mean, obviously, we could all talk on this subject for a long time, so I'll try and keep it brief. I think the crux of the problem is, oh, sorry, I didn't introduce myself. I'm Amir Afzal, I'm a GP. I think the crux of the problem is trying to decide what kind of general practice we actually now want. And it's been taken out of our hands. I've been a GP for near on 27 years. And I can just repeat everything and, endorse everything that's been said and much more. The complexity of our work, we are now what traditionally were the general physicians. The only comparators that are left now is some of the geriatricians, and the people around, most of the people around this table actually know this. People like Zach have been talking about this for years. So we've taken on a huge amount of secondary care work. And then on top of that, it seems as if the whole of society ills have come at our doorstep. It's somehow we just seem to be responsible for everything. And somebody at some point needs to start drawing boundaries. One of the saddest things I heard was day before yesterday when I appraised a very nice, bright young GP who ended up by saying, I didn't come into general practice for this, left the salaried post, is doing some locums while looking for something else to do. But the saddest thing was that she was only 4 years post VTS. She was only 4 years qualified as a GP, not 25, not 27. But after 4 years, she's come to that conclusion. And I think that's because of the last, particularly the last couple of years, but over, slowly over a period of time. And from dealing with literally life-threatening conditions, dealing with incredibly complex medical conditions on top of which there is huge amount of social needs, trying to sort that out. Some of our surgeries are burdened with things like a patient who got quite aggressive with one of my partners because the battery in his tag wasn't working, so he deemed that appropriate to come and see a GP. A patient ringing me up and saying, my solicitor says I need X, Y, and Z, absolutely no clinical reason, got annoyed and said they were going to put a complaint in, when I kind of pointed out that we'll get the solicitor to write to me, because this, on a day when I'm seeing 130 patients, which was on Monday when I was on call, I'm sorry, but that I don't think that this kind of thing should be taking up my time. So yeah, untenable. And I think it needs a much wider societal conversation as to what kind of general practice in particular and primary care in general we want as a society. Thank you.
Thank you for those comments, Amir. Judy, I'll bring you in next, please. And it would be interesting as we go through our reflections on this, as we generally do this as a story from the patient's perspective, it would be interesting to draw in some views about how some of what we've heard in today's video is impacting on people who use our services and our patients as well. So I'm going to bring Judy in, please.
Thanks, Terry. I'm Judy Thorley, I'm lay member. It's hard to watch and listen and see someone talking and quite distressed and obviously sort of overworked. You can see that. I don't want to sound like Donald Trump, but there is an issue in terms of the news and the way that that's delivered. And, we could say that some of it's fake news. But for me, part of the solution, and I think what we have always done well in Sheffield is that listening to and hearing what our patients and carers are saying too. And I think looking to understand why, understand the narrative, to then work together to co-produce what primary care looks like in the future would be really helpful. Acknowledging that we have some real horrific issues, access for being one, and the issue with telephone contact and getting appointments, etc. But on the flip side, we've had some fantastic progress during the pandemic with things like video consultations and other innovative approaches. So I think part of the solution is listening to and hearing our population.
Thank you, Judy. Greg, please.
Thanks, Chair. So I'd seen the video before. It's very, very powerful, and I use it a lot. So four main observations, really. One, there's something about calling this out. A lot of this is whipped up by certain sections of the media, not locally, I may add, but so a lot of it is whipped up by certain sections of the media. So that does need calling out. And secondly, flip it. To tell stories of where it does work, because there are we all like to hear about stories of where it doesn't work, and lots of people grumble about that, rightly and understandably. No one ever tells us stories about where it does work, and 90% of the time it probably works really, really well. It's worth acknowledging people have legit frustrations, and it never works perfectly. It's worth acknowledging that the frustrations people have are legit. The evidence, and I think Ben will talk about this, so I may steal his thunder, and sorry if I do, says that most people are very, very happy with non-face-to-face. The evidence is really clear on that. The Ask My GP model says that most are pretty happy with non-face-to-face. I'm a patient, I'm perfectly happy with non-face-to-face, and it works really well for me. Thank you very much. Lastly, I agree with Amir on the sort of the fundamental rethink of the model, and you call out the fundamentals in this, and there's something about going forward. The purpose of the ICS will clearly be about the NHS constitutional pledges, and I get that, I understand that, that's important. But if it doesn't address the burning platforms, and here is one of them, and it's burning very brightly, it will sort of meet the target but miss the point. And there is something about we all want the left shift, whatever that actually means. Well, the Lancet LSE Commission on the Future of the NHS tells us very clearly we're doing exactly the opposite of the left shift and have been doing for about the last 30 years. So if we don't turn this round as an opportunity to fundamentally redress some of that, then I think we'll have missed what is at the moment a quite painful space and a difficult thing, but it is also an opportunity. I shall shut up there.
Thanks, Greg. I'll take comments from Ben and then Marion, please.
Yeah, so I mean, it's similar to what some of the people have said already, really, that I think that the risk potentially with the kind of the burnout narrative that of GPs can be that it misses the validating patient experience, because patients say we can't get the care that we want, and we say we can't work any harder. It kind of like ends there, but actually it is important to acknowledge that it's really it can be hard for people to get care, and we do need to spend time listening and thinking about what some of those solutions are. And I think that communication is such a large part of the frustrations, actually. So part of it is not having the access and not having the capacity, but a lot of it has also been around communication. So the narrative, I think, is really important, and I think engaging with the media to try and kind of if people can see that general practice is working as hard as it can, and we're on the same team trying to do the best that we can, that I think that sits differently with a patient, hopefully, if they're trying to get care and they realize that we're doing the best that we can. I think that helps to kind of to cope with it if you're not getting the service that you want. But also it enables, I think, patients to be a bit more flexible with the changes that we are making. And I think this is quite an interesting thing around the frustration for patients can kind of fall into two categories. One is the problem and one is the solution. So the problem being I can't get an appointment. Okay, I think that's a valid, like a valid concern. But some of the solutions are what's frustrating people as well, and I think that's where some of the communication could be improved. So we're not going to get any influx of GPs anytime soon. It's going to be all the additional roles that are coming in, and so when patients ring up saying I want an appointment to see a GP, and we say actually can you tell us a bit about the problem? We need to be able to ask you what the problem is. That's a frustration. People don't want to talk to the receptionist, and then they don't want to see the physio, the paramedic. These are the roles, but actually working out how they fit with the team, and how the work can move around within the team. And then also there's the question of kind of how you get seen, whether it's face to face or whether it's by phone. Again, I think that because there's been so much rapid change within general practice, it's been very unsettling. I don't think it's come along with the communication that's required to actually enable patients to come on that journey with us, and again, be on the same team about it, and realize that you might start with a phone call, you might start with a physio, but it doesn't have to end there. It might be that if the needs transpire that as you go through, that we can be flexible and we can see you in the way that you need. So it's around the care navigation and using additional roles and communicating with patients and really saying, yes, this is hard. Let's work together to get the best possible care that we can give right now with the people that we've got. And I think that's a lot of media, social media, and I think we may even be doing some kind of Q&A, some live Q&A where patients can really kind of grapple with this stuff. Because I did it in a patient group meeting. There was 10 people, probably average age 70, 80. It took about half an hour to really explain this, and at the end they were like, "We get it, great, we understand now." But it took half an hour. That's not something a few paragraphs will do. So it's how do you do that on a scale across the city? I think that's kind of what's needed. And then just one other very small thing I may have mentioned around boundaries. I think general practice is generally thought of as the place that you go for a lot of problems, and most people don't know what the contract is, what we actually contracted to do. Even GPs don't know actually, but patients also don't know. And I think some communication around kind of what we do and what we don't do would also maybe reduce some of the demand. There's a few thoughts.
Okay, thank you, Ben. I can see there are a few more hands up. We are running over agenda time slightly. So if I could ask governing body members to try and keep the points brief and also try not to repeat anything that we've said already. But over to Marion, please.
Thank you. You can hear me. Yeah. Well, I'm very grateful to Sarah and Neil for almost kicking this off last week. And Mark, you've had a chip and a stir of the pudding. And Chris Bentley's talk last week was on fire. I thought it was really, really good. And one of the things that really resonated with me was the variability in the city. And it's not the poorest quintiles that are throwing up the most complaints. And so there's something here about there's supposed to be an equity of provision in terms of finance into practices, but the experience that the patients get. And we've got to remember the patient is at the centre of this agenda. We've got to see if we can try and get the patient what they need one way or another. So some of the patient experience was best where you were very surprised to see it. Now, how do those practices achieve that with the tools they've got? We mustn't let this degenerate into a GP moaning department, because it could easily do that. What we've got to remember is the patient. Now, the main access into practice is by telephone. And if you're deaf or if English is your second language, that's not the perfect solution. So we need other ways of getting hold of the GP. And Mark, you made the point last night that you can phone 200 times and still not get through. Now, sadly, that is true. And we have people saying that to us, that they've got the phone on redial, and of course, then they get frustrated. And then when they do get through, and this is where the complaints are generated. So if we can have lots of ways of getting the messages in, we can do our best to solve those problems. But then we've only got so much staff. So what do? I had a read at the papers for this month's meeting, and you can see there's been a huge spend on locum fees. Now, I was going to ask Jackie that question. What are those locum fees? Because I think the extra clinics that are being put on by Primary Care Sheffield to try and address some of this demand, and that's great, but why isn't that extra money being put into the primary care teams who can solve these problems more cost effectively? Primary care is very innovative. It's light on its feet. We can change in a thought. We can do this, but we're needing more tools. That's oh yeah, one last thing, Ben. Thank you for some contribution you made yesterday about sending stuff out through Accurix. I think if we can work smarter, we can cover the ground faster. And some of the quick work that we've been asked to do in obesity, hypertension, diabetes, we could do at the stroke of a button. But a lot of practices haven't engaged that. We hadn't even thought of it. So thank you, Ben, for flagging that up. And really, if we can work smarter, then that must be helpful to everybody. Thank you.
Thank you, Marion. I'll take two final points then from Mark and then Judy, please.
Okay, thanks. Just to be clear, Marion, I claim no credit for that information. It was Sarah who went away.
Yeah,
and
it was. Yeah, but you flagged it up and brought it back up to the front line.
Yeah. So I think, I mean, there's a lot being said, and I do think I agree with a lot of what people have said. There's no point us wringing our hands over this and going, oh, this is just horrible and terribly unfair. I think Zach hinted at this, but this is a government that is looking, when things are under pressure, it looks at who to kick, and it's kicking primary care and general practice. And I do think that we could do more in terms of getting out, and I think the points that I would strongly support some action, which is around providing evidence, of the awful comments that have gone in, but also views from others outside, whether those are advocacy organisations like Healthwatch or others, saying this is the experience. But if we're going to tell that story, it has to be a balanced one. And we know, and what we've been talking about here is it'll only have any credibility if we also say we know that there are things in our own backyard that need fixing, and we have to get, we have to do both of those things. So I think I think I just want to point out that I was very heartened by Ben's point. One of the key things here is about allies. And we made a valiant attempt a few years ago to get patient participation groups up and running. We passed that piece of work over to Primary Care Sheffield. Sadly, not a great deal seems to have happened. Patient participation groups are still being flagged up as important in the new world, and it's part of our legacy we should put back to the development of integrated care systems. If we don't put the work in to developing those relationships with patients in practices, then the first line of defense, the people who will actually stand up in Ben's practice, they might be a bit old, Ben, but nonetheless, those 70-year-olds are the ones who I'm sure, could be prevailed upon to say, this is what it feels like from my point of view, and this is what I expect as a patient. If we don't have those relationships and those PPGs up and running, then one of our key allies, local patients, are not going to be advocating on behalf of general practice.
Thank you, Mark. Judy, please.
Yes, thank you. 3 brief points. HealthWatch gets a lot of patient feedback, and some of it's critical, but a lot of it is really positive. And I'm going to go back to colleagues at HealthWatch to say, let's raise that up, particularly about GPs, to tell another story. Second point, where it's not so good, it's often around communication. I think Ben's absolutely right. And sometimes they are really quick fixes that if there'd been a conversation before a change, like the use of keypads, you would avoid some of the bad stuff, not all of it. But the third one I'd want to put in a bigger context is that it seems to me GPs are picking up the result of 10 years of austerity. There aren't the support systems that were there that would have supported people. Mental health drop-ins, for example, many others. So it seems to me you're the last port of call. So I think there's a really, absolutely take Mark's point about finding allies and advocates outside of your system who'll speak for you and who will make that case in communities. And I think I look to, the communications people to work with us and others who want to make that point on behalf of patients. So yeah, an offer there, I think.
Thanks, Judy. So we've had quite a lot of discussion and comments there, and I'm going to try and summarize those in a couple of sentences. I think that might be an impossible task, but bear with me while I try. But we've seen a video which is demonstrating really quite difficult situation in primary care. We know that there are difficulties in other parts of our health and social care system as well. This really is the kind of the point at which all of our services are really stretched, and we're all beginning to feel that. And unfortunately, and it will be a small number of patients on the backdrop of a media narrative are really painting quite a bleak, unpleasant picture that is having a negative impact on our staff and our workforce, and therefore that will impact on the ability that we have to offer those good services. I think, Marion, I want to draw on your point that everything we do really is about putting the patient at the centre. And as we go through this, we are in a state of change. The pandemic has accelerated change in primary care, but whilst ever there is change and there are changes going on, it is difficult for the people who are using the services, but also for the staff working in those services that are changing. And Ben has highlighted that a traditional romantic view of the general practitioner, the family GP, that is something that has been changing and will continue to change over time as we begin to bring in different healthcare professionals to work alongside GPs in their practices, serving those communities. And I think one of the key threads that we've heard through the discussions here is how do we involve and engage our patients in communicating those changes, and also advocating in their local communities for those changes, so that we can begin to unpick some of the difficulties that we're having. I think the other bit, just picking up on, I believe it was Marion again, playing back some of the discussions that were had during a CCG primary care development session previously, is actually in Sheffield, we're one of the few large cities in the country that's got really high quality, good or excellent primary care services. And I think that's something that, you know, we should rightly be celebrating, but recognizing alongside that, that there remain some difficulties for patients accessing their services, and with a job to do yet in taking our patients alongside us as we change. So I think that might have been more than 3 sentences, slightly more there. Zach, final word over to you if there's anything that you wish to add.
I think you've probably pretty much covered it, Terry. I think it's really having an honest and open conversation with the public. I think all of us would say we'd love to be able to offer more access. We are really trying, but it would be really good to have that conversation. I'd really reiterate what Mark said about the patient groups. We've got a really strong patient group within our practice that actually, if I'm brutally honest, protect us too much and actually defend us too much. But that can be hugely powerful if you can create that relationship. So I'd be really keen to try and find out why that's stalling. And I know it's difficult when people are so busy, but I think that is an investment that's really well worth it, is to try and get your patient forum up and running, try and link them together so that we get that across the city. So I'd be really keen to take some of that stuff forward as well. And also obviously working with Healthwatch.
Thank you all for your contributions to that discussion. I'm now going to bring us on to part 2 of the agenda, which is papers for approval. So item 8, and that's paper C in the noting pack, is the CCG planned submission for October 21 through to March 22, which is termed as H2. So the second half of the year, and the revised budgets for that period. I'm going to hand over to Jackie, Mills and Sandy, please.
Thank you, Chair. So I'll start us off. So my name is Sandy Buchan and I'm Director of Commissioning Development. The paper is to update governing body on the national planning guidance and a subsequent submission. So the guidance this year has been published in 2 parts, H1 for the first 6 months of the year and H2 for the second. H1 was published in March and subsequently submitted, and H2 was published in September and will be submitted on the 16th of November. As in H1, we've been asked to submit an ICS system plan, but places and organisations are submitting the granular detail, which will then feed into that overarching South Yorkshire and Bassett Law plan. The paper itself details the timelines and deadlines that we're currently working to, and it also discusses the priorities that are within the guidance, which remain the same as what was detailed within H1. So on this submission, we're providing an update to those plans that we previously submitted. The paper also details some activity assumptions around priority number 3, which is the restoration of elective and cancer care and the increase in demand in mental health services. Currently, we're meeting across Sheffield with planning leads to update the plans and look at the achievement of these assumptions, bearing in mind the current pressures and challenges the system continues to face, which we have already discussed in regards to primary care. As yet, these haven't been finalised, and therefore, as part of the paper, I am asking a governing body to delegate the sign-off of the final plans to Leslie, our accountable officer, prior to the 16th of November. So in regards to the activity plans, unfortunately, I'm not able to bring an update to this meeting because we are still scoping that work out across the system. So if I could just hand over to Jackie now, please.
Thanks, Sandy. So I'm Jackie Mills, I'm Director of Finance. I just wanted to remind governing body that we approved the full year financial plan for 21-22 at our meeting in March, and that considered some of the initial challenges. We knew at that point that we were still waiting guidance from NHS England on the H1, the half one arrangements, and that arrived at the end of March. So we submitted a revised H1 plan, and that was considered by governing body in May. So this is actually the third iteration we've had of financial planning for 21-22. So the planning guidance, as Sandy confirmed, arrived on the 30th of September for the second half of the year. So we have been working with colleagues across the system to understand that guidance. Updated system allocations were issued alongside that guidance, and we have had a debate across the ICS about how that distribution of system resources will flow to organisations. So that work has concluded, and that means for Sheffield, we're anticipating an allocation for the second half of the year of 587 million. That's actually lower than the allocation we received in H1, but that's because we received a number of one-off allocations in H1. So there is a table in the report, it's table 2 on page 7, and that shows a comparison of the underlying change in the allocation for H2, which, if you exclude those one-off things, shows an increase of funding for the second half of the year of 7.5 million. That excludes the funding that we host for the ICS. But it should be noted of that increase, a big chunk of that funding provides for the back pay of the NHS pay award. So that was agreed and paid after the H1 allocations were agreed. So most of that funding will transfer to our providers. So the paper sets out the approach for setting budgets for H2, and it also notes that the budgets for H1 will be rebased at month 7 to reflect the actual outturn, so that full year budgets will reflect our latest estimate of need. The paper also covers some of the pressures in a number of areas where growth outstrips the national assumptions on growth. And that's particularly the case in CHC, where we have seen significant growth in our spend on CHC. The national model also assumed that we've delivered our H1 position, and whilst, and we'll come on to this later in the meeting, whilst this is the case, the position has been balanced by a range of non-recurrent measures. So that means we're taking a level of spend into the second half of the year that's higher than would have been assumed by the national model. So on a bottom-up basis, the forecast deficit for H2 before we consider mitigations is a gross deficit of 8.2 million. And I have set out in the paper what I think the proposed mitigations are. So the biggest element is our QUIP programme. So I've set out in the paper the targets for QUIP savings from our prescribing, CHC and running cost work streams. And they identify schemes equate to just short of £2 million. I do need to note that there are different levels of confidence on the deliverability of these, but in the round, I think that is a reasonable expectation of efficiency. In addition to that, there is an unidentified QUIP target, which in effect is a risk that we have in the plan, as we've had in previous times. This is where we still need to identify plans to deliver financial balance. The remaining areas of mitigations as set out in the paper relate to £3 million of income slippage, which is where I believe we can demonstrate achievement of the requirements of various funding streams, but without having to commit the full level of funding. Together with the utilisation of our contingency reserve that we have and expectation of further expenditure slippage. So on the basis of these assumptions, we submitted a draft financial plan, so that was required before the end of October. But when we submitted that draft plan, we did identify a range of risks, and I've set out those risks in the paper. As always, we'll continue to carefully monitor those risks, and where appropriate, we'll agree actions to manage those risks if I feel that we're not able to deliver financial balance. So what I'm asking for today is for the governing body to confirm, having considered the information in this report, but also the risks, that you're supportive of me submitting a balanced financial plan when the final return is required on the 10th of November. So that's the deadline for the draft, the final organisational financial plans to be submitted. And then finally, the paper sets out the full year budgets for the revised full year budgets for 21-22 based on actual performance in H1 and the revised budgets in H2. And these, if approved, will be used as the basis of the budgets going forward. So there's quite a lot of information there, and I accept I've gone through that fairly quickly. So I'm happy to take any questions or comments in relation to that, or anything that Sandy's highlighted as well.
Okay, thank you. Any questions or comments for Jackie, please? Chris Neal, please.
Thanks, Jackie, for an excellent report. And I know we don't get the actual allocation till really late to do this, and it's much more difficult with these split allocations and a lot of unknowns at the moment. I just wanted to recognise, I suppose, I'm not looking to resolve it, but you know, there are issues of capacity that are affecting performance and for the community of Sheffield, and I'm particularly concerned about the mental health ones, and including the children, and because of the, well, I'm concerned about it full stop, but with children, the impact for those ACEs, which are those childhood incidents, and getting that support at an early stage. So I know I'm not asking you to resolve it, but I just wanted to make a point about that as how big a priority it is, really. Thanks.
Terry, do you want me to come back on that now, or wait till?
If you want to come back, yeah.
Yeah, I suppose, Chris, what I've highlighted in here is the position in terms of the allocation received by the CCG and the pressures. I am aware that there is additional funding elsewhere in the system that may well flow, and there are non-recurrent funding streams that we're still discussing that are coming down that may address some of the short-term issues we've got. So there is some more encouraging news still to come. I think it's part of the challenge, and I have described it previously. We are balancing multiple different funding streams all coming in different ways, whereas previously we've been used to getting one allocation and agreeing how we deliver our priorities from that. So it is a constant juggling at the moment in terms of our core allocation, but also the other funding that we may have access to. And the thing that is most challenging is all of this funding is short term. We still are unclear about our recurrent level of resources from April onwards as we move into the integrated care arrangements. And you know, it's really those that information that will really allow us to make sure that we can make progress on those things that we've identified as important to us.
But I'm pleased that there is some funding streams coming in differently, because it does give us some options about being proactive and looking at some of the things we've just talked about with primary care, for example, and I'm focusing on mental health. Yeah. I'm pleased to hear that, because it just gives you a bit more leeway and how you can resolve some of the things that if you just do it how we have always done it, it's going to take far too long, really. So thanks for that.
Okay, Greg, please.
Thanks, Terry. Thanks. Hugely helpful, pithy, coherent and well put together report. It belies the immense complexity underneath it. Just a brief observation. Yes, it's a report about the commissioning plan, and thus focuses on the sort of the machinery of the asks of an NHS commissioner. The observation is it's never quite in kilter with some of the real burning platforms. We talked about primary care, one of them, for quite a long time beforehand, and the machinery of commissioning never quite keeps up with some of the burning issues. And Chris made the point about short-term funding versus long-term needs, so I won't repeat that. It's whilst no real complaint about the report at all, and very happy to accept it, the left shift doesn't feel palpable within it, and perhaps nor does the inequalities point feel palpable within it. I get what it is, it's there for a purpose and it serves its purpose very well, but the machinery and the burning need doesn't quite get matched, I think. Just an observation, no need to come back with a long response.
Thank you, Greg. I've just spotted Sandy's hand go up there, so did you want to come back on that point?
I did, thank you, Greg. Could I just make a point that we do have the CCG's operational plan, which includes the joint commissioning plan with the council. So this is the national planning guidance, which has specific priorities for the NHS, which, as you'll see in the paper, is quite heavily towards elective restoration and the acute sector. But our operational plan and our priorities within the CCG are very much geared towards the health inequalities, the joint commissioning work with the local authority, as well as working in partnership and integratively with primary care and social and secondary care. So we still have that plan that we are working very much towards delivering, but this is obviously part of the statutory requirements of our national guidance.
Thanks, Sandy. Brian, please.
Thank you, Chair. And I should have said earlier, Brian Hughes, Deputy Accountable Officer, and introduced myself. And I'm not sure, this does feel a little bit like Groundhog Day. And I don't know whether Jackie or Sandy, I said it on the first version of the plan that was submitted, or the second version, or now that we're into the third. But this seems to become more complex. And it seems to be that we're looking around in different pots to make sure everything knits together. So I just wanted to thank you both for the paper that does present in as coherent and concise a way as possible, something that is truly really complex and has been made, I think, even more complex in the year or the 18 months that we've been in. So I want to support the asks that's in it about the idea of submitting a balanced plan and recognise the risks that go into that plan, but also the actions that we as a governing body and as a team will undertake to make sure that we deliver on the plan that we will submit in November. So thank you to you both and the teams.
Thank you. Lee, please.
It's Lee Salisbury. I'm a GP on the governing body. Brian, you've just taken the words out of my mouth. So just to echo that, I just wanted to say thank you, Jackie and Sandy, and to all of your team, because, you know, we rely on you month by month to sort of decipher all the financial intricacies. And each month I just keep thinking this is getting more complicated and more difficult. And so recognising the difficulty of the work that you're doing, but also the frustration in that, you know, normally we're on an annual cycle. Now we've been on a 6-monthly cycle. And in terms of actually what you really want to do with that money, I know it isn't just about balancing the books, it's about using it to the benefit of the population. So just to sort of echo what Greg was saying, we absolutely understand that carrying on as we are doing and focusing on the high end, high cost side of healthcare, it isn't sustainable. And isn't the direction of travel, and yet we're sort of forced into this mold of working, which we know doesn't work. So, and I'm sort of reflecting as well on the conversation we had about primary care as well, that part of the frustration is that within primary care, notwithstanding the capacity issues and the demand and everything else, it's the conflicting directives that come. So if we remember back to pre-COVID, it was all about remote consultations and forcing these sort of dinosaur GPs into different ways of working. And then suddenly it's, oh no, that's the wrong way to go, you know, despite the fact that they shifted, you know, within a couple of weeks, everything had changed. So, and it's that sort of lack of control, and also being asked to do things which actually, you know, aren't in the long-term best interest of the population and the system. So I suppose the point of what I'm saying is, apart from thank you, is being mindful of where we are as a place going forward, in how we can use whatever levers are within our control to start to influence the way that services work, that are going to make them sustainable for the long term and also fit for purpose for the population that we serve. So thank you. Don't give up, but let's see how innovative we can be within the envelope. And I know that you are.
Mind if I just come back on that, Terry? So Lee, there's a further presentation in our private session from myself and Sandy where we actually want to explore the opportunities for some of that. So hopefully we can have a bit of that debate and help us help develop our thinking there.
Okay, so this paper is specifically asking governing body to approve the revised full year budgets and agree the financial plan submission. So could we just confirm that now? Okay, Thank you, Jackie. Maybe, I know you've still got until the 17th, so something will change, I'm sure. Some other ask will come down, but fingers crossed it doesn't. And hopefully you can have a bit of a sigh of relief and hope that there won't be a fourth planning submission for this financial year. I just want to echo what everybody else has said. Thank you to both of you and to your teams in pulling together what has been probably the most complex set of financial guidelines and rules and funding streams that any of us have seen before. So thank you. Okay, item number 9 now, paper D in your noting pack. So I'm going to hand over to Kath to introduce the proposed changes to the standards of business conduct and conflict of interest policy. Over to you, Kath.
Thank you, Terry. So I'm Kath Turney. I'm the Associate Director for Corporate Services. And I'm thinking this will probably be a quick item, but I shouldn't say that because that's tempting fate. So back in August 2020, governing body approved the standards of business conduct and conflicts of interest policy, and it was agreed that this would be reviewed before the end of February 2022. Because of all the changes afoot, we're trying to kind of get things tidied up where we can. So that's what we're doing today. So we've worked through, made a few small changes, which are it's quite a big document, so they're in the papers for noting. The changes are mainly around job titles and building in some recommendations from our internal auditors. And that was linked to the audit of the management of conflicts of interest. We ideally would have taken these through the Audit and Integrated Governance Committee, but due to timings of meetings, we couldn't do that, but that's been shared virtually. We've had some comments that have helped shape that, and the Audit Committee is recommending them to governing body for approval. In Appendix B, the policy sets out requirement for members of CCG governing bodies to understand and be committed to the practice of good governance and to the legal and regulatory frameworks in which they operate. Most governing body members have signed the statement linked to that, but we've had a few people since when that was carried out that haven't, who've joined since. So we will send that through for signature, but we're not planning to redo all of that unless people that haven't. So that will come out after this meeting. So basically all I'm asking for here today is for governing body to approve the proposed changes that we've shared with you.
Okay, thank you. Does anybody have any questions for Kath at this stage? Okay, so noting the changes that have been highlighted, are we happy to accept those? Okay, thank you, Kath.
Okay.
Okay, I'll move us on to part 3 of the agenda now, which are papers for consideration. So you managed to rattle through your paper really quickly there, and I'm going to go back now to Jackie to give us an update on finance from month 6 onwards, and that's paper E in your noting pack.
Thanks, Terry. So this report covers the whole of the period covered by the H1 allocation that I've just referred to. It's important to note that in month 6 we received an allocation for our historic surplus. So we now have to demonstrate our continued delivery of that level of surplus. So I'm pleased to confirm that the report shows delivery of that position. So we've in effect met the requirements of delivering a balanced position. The report sets out some of the key issues in relation to different budget areas, and I think we've covered many of those on previous meetings. So I did just want to go back to the question that Marion posed around the level of locum spend. So that is actually in relation to reimbursement of locum spend for sickness and maternity. We've had extremely high levels of sickness, and I think some of the issues around primary care capacity that we've discussed earlier have been impacted by those levels of sickness. And obviously, we've had some long-term absences that have had a significant impact on that budget. You also referred to, though, Marion, about what are we doing around different areas of response, and you mentioned the primary care hubs where we've invested in additional capacity. That funding's come from our COVID funding and is reported through our extended access spend. But there are discussions at the moment about additional support that we can provide into primary care from one of those, well, a number of those additional non-recurrent funding sources that I've already mentioned. So those discussions are ongoing, and we're hopeful to be able to confirm the support that we can give in the near future. Quite practical support. Again, short-term funding, you know, it will be a sticking plaster on some of the things that we need to work on the longer term, but I think is hopefully going to provide some support to some of the things we've discussed. So I wasn't proposing to bring anything else out in terms of the issues in the report, but as ever, I'm happy to take any questions.
Okay, any questions for Jackie, please? No, okay, thank you. I'll take us on to the next paper, which is item 11, paper F in the noting pack, and that's a month 6 performance and delivery report, and you're introducing that for us, Kath.
Thanks, Terry. So I'm just going to highlight a couple of points from the paper. In relation to the NHS constitution measures, the position remains largely the same as it did when I presented back in September. There's been a few ups and downs, but not a major difference. The capacity pressures that we've been discussing earlier linked to the COVID pandemic continues to impact waiting times for planned treatment or surgery. Good news is that the number of people waiting over 52 weeks for their treatment has fallen again by a small amount. However, I think last time I reported that the proportion of people waiting over 18 weeks for their treatment had also fallen, but it's gone up a bit this time. So the report, there's more detail in the report about the ways in which the system is working together to try and maximise the capacity potential. There are also the significant pressures in emergency care, and particularly in this report you see the links to the increased demand on the 999 ambulance services, which is impacting both response times and the handover in A&E. Also, during September, there were 5 people that waited over 12 hours in A&E at Sheffield Teaching Hospital, and all of these were linked to a specific need for specialist mental health care. Sandy Buchan has talked previously about the root cause analysis that was taking place linked to this, and there's been a recent local mental health summit, and there's now an agreed process for STH to follow in relation to supporting the escalation of patients who are in this position. And there's work ongoing to help the staff that are on call at this time, linking both Sheffield Teaching Hospital and Sheffield Care Trust when these circumstances arise. So hopefully we'll start to see less of this occurring in the future. The report also updates around COVID and influenza vaccine campaigns, and Sheffield still remains the highest percentage vaccine uptake for both first and second doses out of the top 8 core cities in England, which is fantastic. Unfortunately, and I normally talk to you about the temperature check that we carry out with our staff on a monthly basis. We had a bit of a technical hitch on that, so we're not able to share that information with you this time, but we do now have that information, so that will come through in the next report. But I would like to update you on is a great staff briefing session we had a couple of weeks ago on the week where it was the National Menopause Day, and we had Dr. Marion Sloan, our very own governing body GP, came and gave a brilliant presentation to, I think usually we have about 150 staff who come on that, talked about menopause, HRT, loads of interest, loads of questions, and people are still talking about it, Marion, so thank you for doing that. I'm sure you helped a lot of people. So yeah, those are the points I wanted to highlight really.
Okay, thank you, Kath. Any questions on this paper? So Lee, please.
Hi, thanks as ever, Kath, for this paper. It's really helpful. I'll just be brief. If we look at page 14, every time we look at this paper, I struggle looking at the IAPT targets. The number of patients receiving IAPT as a proportion of estimated need. And we have discussed this before, because I couldn't believe it the first time I saw it, and I still can't believe it. The national target is 6.25%. So that is 6.25% of people who probably need IAPT. So that's the best we're expecting, which to me is just utterly shocking. We wouldn't accept it if it was cancer. And so and I know it's a national target, but again, thinking about what we can do locally, that is just not acceptable, really. But then to look at actually what we are achieving, 1.84%. So that means that over 98% of people who have got an estimated need of IAPT input are not getting it. So it's as if there's almost no service. And we're drawing to a close as a CCG. Terry, you've got that sort of slightly quizzical look. And I have asked this before. When Jim Milnes was here, I said, is that really, at the time the target was 5%, I said, is that really 5% of all people who are estimated to need IAPT? And he went, yes. So unless things have changed, but either way, 1.84% isn't enough.
I think, Lee, we may need to go back and clarify what that number means. My understanding is the quarterly target is 5.47% of the adult population of Sheffield who would be eligible for IAPT treatment, as opposed to 5.4% of people who need IAPT services. So I think
it would be really helpful.
Either way, we're below where we should be, but I do think we need to go back and check that. I can recall an NHS England review where they're asking us how we would increase that percentage, but I think we should clarify that. But what we are seeing, obviously, on that is not performing against the standard that we have got set for ourselves.
It would be really helpful to clarify for my benefit, because every month I look at this, and as I say, we did try and clarify, and that was the answer I got. So, not to worry. Either way, as you say, we're still way short of where we should be. And I think, the end result of that at the far end is what we're seeing with those excess 12-hour waits. A lot of them did have mental health component to them, and the two are linked. And so I just feel it would be really helpful. I think month on month we do keep saying, not really, it's very difficult to engage with some of the ACT teams. Some of the ACT teams will be doing brilliantly, and it's great, but I think mental health as a whole, we know, is under excess pressure from what it was before the pandemic. It was already struggling, and we've really got to do all that we can to try and address that. I'll stop.
Thank you, Lee. Greg, please.
Thanks, Chair. Quick comment, Kath. Thank you for as ever helpful, excellent paper. I can't think of anything other than COVID at the moment, so this is a COVID vaccination point. Apologies. Thank you for getting the right denominator and the right comparator. As you know, it's a source of some annoyance that we keep being compared to the wrong places using the wrong denominator. So thank you to this performance report for getting the right set of comparators, i.e. similar core cities, and using the right denominator, i.e. the NIMS registered rather than the residents. A request for booting upstairs to the machinery that these NHS England performance could do well with remembering some of that basic epidemiological stuff. But thank you for reflecting it properly in this report, because it does matter, and the city is doing a genuinely amazing job in this space. One quick question or a request, and I'll pick it up in various other spaces offline. A huge amount of confusion about boosters and third vaccines, who's eligible for what, where can I go, etc. The national comms message has been a bit muddled on that one, and again, so we need to fix that locally as best we can. That's my kind of next pressing priority. But thank you for getting the right comparators in that one.
Thanks, Greg.
Jackie, please.
Yeah, I suppose just to acknowledge the level of red in the performance report. I think it's probably the most read we've seen to date, and I think is really tells the story of a number of issues that we're managing at the moment. Lots of parts of the system are under extreme pressure, but it's read for the things that we can measure. And as we talked about earlier, the issues around primary care, because they are less visible in terms of data, don't appear in the same way as some of the other issues. So I just needed to recognise that the performance report is really focused on the data and the things that we're held to account for, but doesn't tell the full picture of some of the multiple pressures that we're balancing off at the moment.
Thank you. Anthea, please.
Just want to follow up on some of the things that Jackie was saying about how read it is. And also, Jackie, you said it's read for the things we can measure, which made my senses sort of pick up, what about the things we can't measure? And that's sort of the what don't we know, we don't know when it comes to performance. And what can we do as commissioners to influence some of these things in the greatest way, bearing in mind we're about to have winter and everyone believes it's going to be a tough winter. I'm not trying to say it won't be, I'm just saying we don't know until we get to the other side whether or not it's going to be a tough winter. But you can't get more red than we are, because that sort of level, we don't have the 5 levels of risks on this analysis, and I'm just concerned that we're not doing everything that I'm not assured we're doing everything that we can do as commissioners at the moment.
Do you want me to come back in at that point, Terry?
Yes, if you'd like to, and then we'll take a point from Chris.
And Sandy can probably articulate this far better than myself, but and in the spirit that we've been working with and are being encouraged to work in terms of integration across the partnership, we have been we have formed a citywide goal in terms of responding to the pressures across the system, and there's a citywide silver, again looking to mobilise additional responses, recognising that whilst organisations have individual responsibility, we will do better where we can come together and make sure we're working all pulling in the same direction rather than having multiple plans that kind of work against each other. So Sandy is really central in that space, trying to coordinate that. It's taking up her work life and plus. So I don't know, Sandy, if there's anything else that you want to add to that. But.
Yeah, thank you, Jackie. So yeah, the partnership working is absolute key. So we started off looking at the winter plans and how we put all Sheffield health and social care, including PCS and others, come together in order to help the system through. It's not perfect. We recognise at the moment that we do need more clinical input into those forums, but we have got operational directors working together to look at the system risks that we all need to work together and help to mitigate as we go through into winter. So we're not just focusing on urgent emergency care at the front door, we're also looking at the discharges at the back, we're looking at social care, the 16, 17-year-olds in mental health crisis, which has already been picked up. That's something that we've all been working on. So there is a lot of integrated working happening in order to as soon as an issue is risen or risk is highlighted, that the mitigation is something that we're all a part of, looking at resolving the problem or putting things in place, and that's being monitored. We meet at the moment, it was said for twice weekly, it feels like daily at the moment, but like I said, there's a lot of things that we want to incorporate into it, and clinical input into that is absolutely essential. So that's what we're and making sure that is going to happen both in primary and secondary care. But just to assure you, Anthea, I mean, it's certainly something I can pick up with you outside the meeting, but there's a lot of plans, a lot of actions, and meeting daily, if not more, in terms of making sure that we mitigate against them.
Thank you. Chris, please.
Yes, it was just about the point Jackie made about the primary care data that we don't have in the same way as we do for the acute sector. And it's been a topic of discussion in the Primary Care Commissioning Committee. We've been particularly looking at how can we measure things. I know that Lucy with comms, we got out some really good infographics about the CCG, but included primary care and appointments and so on, which were really helpful. And also, I know Amir, not to go into the detail now, but we've had other discussions about things that could be measured, and just from some of the data that you could quote from your practice. At the same time, we've recently had use of some data suggesting how infrequently face-to-face appointments are, which was totally inaccurate from my discussions with GPs. So what I'm saying is, I think our earlier discussion about trying to turn some of these issues around also includes how we measure them as well, and also that we're not relying on out-of-date, inaccurate data, which is just worse than useless, really, and didn't help in the policy that the government were discussing recently. So I feel strongly, because there's so much fantastic work, and Chris Bentley's data that's just been referred to that we looked at last week. I hadn't seen some of that before, and that was encouraging to see that information. I've spoken a couple of times, and I still haven't said I'm Chris Neald and I'm a lay member on the governing body. Thanks.
Thank you. Nikki, please.
Hi, Nikki Bates, GP, governing body. The Children's Hospital board today, I was on a meeting with them, and they said that they had 384 children on a 52-week plus wait. Now that seems to me to be a large percentage of the total number of people waiting in the city, and it seems to be a bit disproportionate to the number of children that we have in our population. So I just wanted to flag that up as a worrying statistic as part of this discussion.
Sorry, just to come back on that, Nikki. So the figures that the Children's Hospital quote will be everyone that's the trust treats, and they're obviously their served population is far greater than Sheffield. So the figures in our performance report are just for our Sheffield population.
Okay.
If I could come in here, please. So one of the reduction of 52-week waiters is part of the planning assumptions, and we're currently working on the Sheffield plan to be submitted as part of the planning guidance to look at how we can reduce those numbers in part of the assumptions in. So that work is being done. So whatever the number is in for Sheffield, that is being worked on as part of the planning and guidance submission.
Thank you, Sandy. Okay, Ben, do you want to come in with the final point?
Oh, just very quickly to clarify that denominator about IAPT. So it's the government wants 25% of people who have common mental health problems to have access to NHS funded psychological therapies a year. So that's 6% a quarter. So I'm presuming the denominator is anyone who's coded as having depression or anxiety.
Yep. So I've Ben too. I've also just found the guidance on that one for clarity for Lee. So the denominator is the total number of people in the city with a diagnosis of depression or anxiety, and the numerator is the estimated need is 25% of all of those patients to access that. What it doesn't quite get the nuance around is whether that's a new diagnosis, whether it's an existing one, whether someone's accessed IAPT once or twice. It's the figures are never straightforward, are they? But hopefully that gives some clarity, Lee.
Thank you. That's helpful. It still strikes me as being a very low number, but anyway, yeah. Thank you.
Okay. Just one final question, and I'll sort of direct this towards Kath, but it may be somebody else that picks up the answer on it. In particular, you highlighted the long ambulance waits. And we have had some national guidance in the last week or so about ambulance waits and how they need to change so that there isn't such a long handover period, you know, with an ambulance potentially parked outside an A&E department before somebody gets in. Now, I don't know whether any of those changes and to the guidance have gone through any of the citywide groups, but I wondered whether, Sandy, you've kind of picked that up through working with the Health and Care Partnership in Sheffield.
Very much been picked up, Chair, and it's part of our winter plan that we've pulled together across Sheffield with the mitigation actions. Again, this is the collaborative partnership work where it's not just down to one organisation to deliver the actions, but all pulling their weight and delivering what's needed. So it has very much been part of the discussions and the process in developing the action plan for Sheffield.
Thank you, Sandy. Alan, please.
Yeah, thank you, Chair. Alan Windle, Chief Sheffield CCG. I just wanted to add to that the announcement and the sharing of that letter has gone to all providers and will be picked up through our quality review groups, and just for assurance, but to also remind colleagues that Sheffield CCG currently is the contractor holder quality for the whole of Yorkshire. So we'll be seeking assurance not just from our local providers, but wider providers as well on supporting Yorkshire Ambulance in their need, really.
Thank you, Alan. I'll take a final point from Chris, please.
It's just a really quick one. I just wanted to check in the text. It said that we have trouble getting hold of the flu vaccine. Is that still the same in view of how important this is this time? Has it changed at all? Do we know?
Alan, are you able to answer that one for us?
Yes, there is some supply issues for both flu and COVID vaccine currently, particularly over the next few weeks, Chris. We're working with primary care currently on both vaccines and supply, and seeking opportunities to maximise the flow into the city. Currently, we're working on a South Yorkshire and Bassett Law footprint to ensure that we get as much as we need, but obviously working with primary care just to alert them that there is a reduction in flow anticipated.
Thanks.
Thanks, Alan. Okay. So, and now moving on to item 12, paper G. This is patient safety, quality and experience report. Alan, are you introducing this one?
Yes, I am. Thank you, Chair. Obviously, paper submitted, and I'll just highlight some key points. The nursing and quality team continues to oversee the work undertaken post CQC maternity reports that our Sheffield teaching hospitals received with regards to action and recovery plans, and we continue to monitor those through our quality review meetings. We continue to await the final CQC report from the most recent unannounced inspection. However, this won't be anticipated till probably around December at the moment, as a planned well-led inspection is due for next week. In addition to the quality review meeting that we've instigated within relation to the maternity CQC inspection, a quality board agreed has been established for the maternity outcomes for it'll include CQC, ourselves, and NHS England and Improvement to again oversee the established improvement plans. It's anticipated with with the outcomes of the most recent inspection and the well-led inspection, that this will move from a maternity quality board to just a quality board that will look at all aspects of the report once completed. I'm pleased to share that the Sheffield Health and Social Care Trust Back to Good programme developed post their CQC inspection that rated them inadequate has now been rated as requires improvement, which shows an improvement against the quality board. Again, we established a joint quality board in the response to the previous inadequate, including the CCG, CQC and NHS England improvement. The board is well established and will continue for the foreseeable future, as there is still some key bits of work that all parties are keen to see improve on. But again, it's an improved position which we are pleased about. Our CHC service, continuing healthcare service, also continues to progress a recovery plan for pre-COVID reviews. Members will remember that reviews suspended during the COVID period, which left quite a bit of backlog, but we continue to performance manage ourselves against those and an improving position, but still work to do. Our infection control team continues to support across all our provider services. Our acute trusts have reported a 0 MRSA bacteremia, which is a really positive stance at the moment, and continued clinical support to care home sector continues. System discussions continue to see how the CCG can support further with regards to outbreak management, and myself, the director of adult social care, continue to discuss how we can maximise and support each organisation on care home quality, infection control and safeguarding assurances. This aligns with the joint Sheffield City and City Council and CCG quality assurance framework that also continues to be developed. Progress again was delayed due to the pandemic pressures on workforce, but the project is now reinstated and have already commenced in that joint planning on how we support. As an additional update to this paper, I just wanted the governing body to be aware that the chair of our Safeguarding Partnership Board, David Ashcroft, has offered his resignation, and I personally want to extend governing body thanks to David on behalf of the CCG as a statutory lead partner for safeguarding, for the work and leadership that he's provided to the city. I would like to also advise governing body that the process for recruitment of an independent chair has commenced, and the 3 lead agencies within the City Council, South Yorkshire Police and myself for the CCG will provide continued support to the wider partnership until a new chair is appointed. That's probably the key highlights, Chair. Happy to take any additional questions if there are any.
Thank you, Alan. Amir, please.
Yeah, just a reflection, really, Alan, is more than a question. I mean, it's a real shame, and I know that this isn't something that's in our gift locally, that it's that time of the year when we're looking at QOF again and trying to prioritize the clinical needs is being offset by the usual tick box exercises. And we had a big meeting at the practice trying to prioritize SMI health checks, trying to prioritize LD health checks. On top of that, the homebound flu. And perhaps the most frustrating one out of the lot is the housebound COVID injections, requiring, as you know, 15 minutes our healthcare professionals' time. And in our case, it'll be the doctors who would be doing this because we're a nurse down. Healthcare assistants can't do this. And I just wish that the powers that be could see some pragmatic sense in this, as we saw some sense last year, and let go of some of the less urgent and less critical quaff areas, really. I'm just looking at the bottom end of that. And it is so difficult to try and say, well, where do we put this in? And then the flip side to that, and just is that if we don't do the quaff, then what do we do? Do we let go of one or two members of our team, which would be disastrous in the current climate? It's just a reflection.
Thank you, Amir. Any further questions for Alan? No, Alan, do you want to respond to that point at all?
It may be my primary care director that may want to give, because obviously the quaff leading to quality, but obviously is a performance indicator rather than what I would describe as a quality indicator, but links through to quality because it's the so what question. I absolutely appreciate Amir's stance and view on this, and I think it's a collective view from both the CCG and our primary care colleagues, Chair, so very supportive of that view, and just to assure Amir and our primary care colleagues that we continue to feed back our feelings as well as yours. Hopefully we will get some reflective views back, but again, Amir, we'll continue to share our feelings through the appropriate channels.
Thank you, Alan.
Thanks, Alan. Okay, I'll now draw us on to part 4 of the agenda. We've got 2 items here. The first one is integrating care update. I'm going to hand over to Leslie and Brian, please.
Thank you, Chair. I was planning to take both of the items together and focus on paper H, so I'm happy to do that. And then I don't know whether Brian wants to come in with anything further around integrating care in terms of the local ACP work. We can do that. But if we focus on the paper that's in the pack today, paper H, it's a paper summarising content of the Health and Care Bill and the process that's in place to develop the governance arrangements for the establishment of an integrated care board and its associated integrated care partnership. Whilst this paper is for noting by governing body members, I think it's a useful paper in that it does several things. And the first of those is really just pull together the journey that we've been on since the publication of the white paper earlier in the year, and then moving through to legislation being put before Parliament in July of this year. And subsequently going into the autumn, we've had lots of guidance on the role of integrated care boards, on the role of integrated care partnerships and their constitutions and how they will be established. And one of the things this paper does is just pull together for us a summary of all the guidance that we've received in the last couple of months. And if I reflect back in our conversation this afternoon, I think the importance of this is thinking about how we carry our ambitions for the people of Sheffield and for the future through in light of the changes that we now see and some of this guidance and thinking about what that means. So one of the key things in there is that it's current ICS leaders and the designate ICB leaders are responsible for putting in place the work to establish the ICB, its governance and its leadership arrangements before formal establishment in April 2022, subject to the successful passing of the legislation. So that's quite a significant ask, because I can't see that the legislation will be passed before February. And in previous changes to the infrastructure and structure of the NHS, we tend to have legislation passed and then probably a year, which focuses on how that will be enacted. So I think it's important to note that this is happening in real time. And of course, some of the legislation could be amended before it finally goes on to statute book in the spring of next year. So one aspect of the governance that we've received is a draft constitution for integrated care boards. I think it's important for us to note that the bill sets out that CCGs will be responsible for proposing the constitution and engagement in the constitution. And what we've agreed in South Yorkshire is that we would do that collectively through the joint committee of CCGs. In terms of designate appointments, we're all cited on the appointment of the designate chair, Pierce Butler, who's now started with us in South Yorkshire, and the interviews for the chief executive designate took place on the 11th of October, and we are expecting to hear an announcement on who the chief executive designate will be around the middle of this month. So the time lapse is to so that it goes through the appropriate process for national sign-off of the appointment, reflecting that the post holder will be the accountable officer for the Integrated Care Board. So those are probably some of the key things to note from this. I think another thing that I'd pick out that's worthy of mention is just noting we've had the steering group, which has been drawn from the partnership to work on the design of the ICB as it goes forward. Now that we're into the last 5 months, looking to fine-tune those working arrangements and cease running the steering group, but build its work into the monthly health executive group and with weekly updates to the health and care management teams. Again, I think that's just worthy of noting. I think again within the paper, we've got summaries of the key functions of the ICB, the elements of the constitution that we need to consider, and noting that the designate chair has already started to talk to stakeholders about the constitution and the development and construct of the ICB board, and is currently asking of partners a number of key questions around membership of the board and how we strike that balance between having a very large board that's very representative, but also having a board that's able to discharge its business and to make some decisions. To note, one of the first priorities is recruitment to the designate non-executive directors of the board, again noting the national requirement to have a minimum of 2, but also that there's some local I've lost my words there, that locally ICBs can decide on having more than 2 non-executive directors and give some thought to how that might be constructed. And again, there's opportunities for us as a CCG to be able to feedback on that. And then I think the other thing just to note in there is the boundary change with Bassett Law CCG moving to the Nottinghamshire Integrated Care System, and therefore the renaming of the partnership to be the South Yorkshire Health and Care Partnership from the 1st of April 2022. So happy to take any questions, but again, just asking governing body to note the ongoing progress with the development of the Integrated Care Board and the governance arrangements coming into play.
Thank you, Leslie. This is quite a big paper. That was a really comprehensive update of quite a lot of information. and hopefully we'll hear lots of thoughts on this as we move through the next 10 minutes or so. So Mark, please, you're ready to kick us off.
Yeah, I just think in terms of membership of the ICB board, the first thing is I think what you said was that there's going to be a sort of consultation in terms of this. I think I heard you say that in terms locally. So we will have a chance to feed in, but it seems to me prior to that, we should have a lined take on what we think, how we think as a CCG, the membership should look. You know, the thoughts that were going through my mind, for example, with regard to the non-exec directors in particular, is should we be thinking about one per place rather than two? Should we be thinking about a membership that reflects the size of some of the constituent bodies, which would be a different way of thinking about it? But whatever it is, we need to be thinking about what is best for Sheffield, but also obviously politically, how that fits with the ambitions and aspirations of Barnsley, Doncaster and Rotherham as well.
Thank you, Mark. You want to come back on that, Leslie?
Yeah, I'm happy to come back on that one. It's a bit of an iterative process, Mark, in terms of there'll be the engagement around the constitution. The makeup of the board will form part of the constitution. So discussions on that have started, and we've been asked the questions around, and those questions focus on the construct of the board and in particular size. So that point about how it can make effective decisions and discharge its business and not be too big, that it becomes more of a partnership forum than a statutory board. So there's some questions on that, and I think some of your points we can feed back in relation to those. And then what will happen is those will be turned into the proposals that are going to sit within the constitution. And again, they'll come back to us with a view of us going back again by the 26th of November with any follow-up points that we might have.
Can I just quickly come back? I mean, one of the things that I think should be in the mix when we're talking about size is people get excited about that sometimes. And you know, as a CCG, our governing body, our statutory board is of a certain size, and I think if it was, for example, a South Yorkshire wide board was smaller than that, it is basically saying that we weren't effective or efficient. So I think we should be thinking about how it compares against current size of boards that exist.
It's an interesting feedback. I'll let Leslie come back on that. But before then, I think there's something about recognising, Mark, that there's the statutory unitary board of an ICS, but we're also talking about a lot of the functions of ICSs actually happening at a place level. So whilst you may have a small slimline board potentially working across system, you may well end up with 4 place-based boards which will have a different mix of people involved in them. And I think there's something, you know, I'm glad I'm not in Piers' shoes here, because there's something about striking that balance appropriately. But Leslie, I'll bring you back in with a response.
Thank you, Terry. Yeah, I think that's one of the key points. And while you were saying that, I was turning to Annex 3 in the paper, which is the functions of an integrated care board. And interestingly for me, I think a number of those would be discharged through a Sheffield team. So if I look at 3, functions 3 around the joint working arrangements with partners, and 4 putting in place arrangements for allocating resources and contracts and agreement to secure delivery with local providers. I think those are things that you'll start to see enacted through the Sheffield team within the overarching integrated care board and partnership. And I think, Mark, it's also worth reminding ourselves that we have both the statutory board and the integrated care partnership, which will be a joint committee with our local authority partners. So we do have to think about the representation and membership of both as well.
Thank you. Mark, if there's anything in particular you would like us to feed back, if you notify Leslie or myself, we will pass that over to peers so that they can be considered as part of that iterative process, really, and making sure that those thoughts are taken into account before it comes back for consultation. Probably best to get those in before, rather than be consulted on some plans that we're more sceptical about. So yeah, and that's the same for anybody on the governing body or beyond. Actually, do feed those thoughts back to us. Okay, any further questions at all for Leslie? No. Okay. I'm looking over to the right-hand side of my screen now and just wondering, Brian and Sandy, you're kind of both sat in place-based partnership roles. And I wonder, Brian, if you want to give us an update on where things are in terms of the Sheffield partnership working, and then we may ask Sandy if there's any further detail in particular around the joint commissioning element of the partnership that you want to bring in.
Thank you, Chair. And the only thing I was going to add sort of to what Leslie has been talking about, the establishment at an ICB level, is the translation of that into place. So we continue to work with our accountable care partnership and our partners across Sheffield to make sure that the arrangements that we will put in place match the expectations that of the paper that Leslie's just been taking us through around the accountable care partnership and the presence and role of place within that. I also wanted to pick up, and I think Sandy will probably come in at that point, around the ongoing development of our joint commissioning committee to make sure that the functions that can be discharged at place have a secure home and future sort of within that. So that was the only bit, Terry, that I was going to add in terms of the paper that is presented needs to be translated into the Sheffield place arrangements, but our partners with us across Sheffield are working on that through the Accountable Care Partnership. Sandy, is there anything you want to say on recent developments within the Joint Commissioning Committee?
I would only add that, so we're currently in the development stage of that. We are further down the road in terms of where we're getting with that. I know governing body has been a part of the development of the revised governance structure post March. We're currently taking that through the Joint Commissioning Committee and the cabinet members in the council. But in terms of our joint commissioning plan, we're very much in the next stage of looking at our 22-23 plan. So in regards to how we're working in that partnership space, we're very much embedding that's the way moving forward to our commissioning intentions. But we are just revising the governance, and it's been a bit of a journey that we've been on in terms of ensuring it's what's right, what's needed, and is aligned with our ACP colleagues and moving into the ICB. So that will be presented back to governing body in the near future.
Thank you, Sandy. Any comments or questions for Brian or Sandy? Okay, thank you. I'll take us then on to part 5 of the agenda. There are a number of reports circulated in advance for noting. Does anybody wish to bring up any points on any of those papers? No. Okay. Does anybody have any other business that they wish to bring up? Okay, thank you. So bring us then to the end of the meeting. As always, if I could ask some volunteers from governing body just to share one key reflection with us about what you're going to take away from today's meeting, what you'll be discussing in your GP surgeries, what you're going to be discussing in your teams in the CCG and beyond. So does anybody have a reflection they wish to share? Chris, please.
I'm just looking to see if one of the GPs has got a hand up, because the point I was going to make is the really, useful discussion and considered discussion about primary care and our desire to reflect on how we can do some of this differently to help with some of the issues we've identified, and certainly that's a priority through the primary care committee as well. So that was a key thing to me, and it's been reflected in other discussions as well about performance and so on.
Thank you. Lee, please.
Hi, yeah, it's just a thought really, rather than an observation on what we've been talking about. Obviously, there's a lot to think about in terms of pressures. There's a lot to think about in terms of risk and uncertainty, and there's a lot to think about in terms of what the future is going to look like. And all the time in my head is a line. I think I read it recently from an NHS England document about taking what we've learned from what went well in managing the pandemic, and applying that to how the future system looks going forward. And I think it's a sort of it's got a good and a bad side, hasn't it? There was lots that was really good in terms of breaking down barriers between the sort of traditional siloed services and the fleetness that could happen, the decisions that could be made quickly, that were appropriate, that meant that the population of Sheffield had, a really, I think, have benefited, particularly in terms of the vaccine rollout and everything else, and maintaining the service even in a difficult time. And so my disappointment in that is that I feel like we're sort of rolling back, and there's a danger that we could get admired again in bureaucracy and rules. There absolutely is a need for really robust governance, but we don't want that to bog us down if we want to sort of move forward and become fleet and responsive to the needs going forward.
Thank you, Lee. David, please.
I'm proud of us as an organisation for bringing this primary care story, because yes, patients are at the forefront of what we do, but we are a membership organisation, and our membership of GP practices, I'm pleased that we are supporting them rather than joining the queue to kick them. And I think that yes, everything everyone said about it, patients being at the forefront, patients being important, the most important thing, that's all true. I don't not disagreeing, but I am pleased that we're standing behind our membership.
Thank you for that reflection, David. Amir, please.
Yeah, I think the theme is heavily towards primary care. My take-home point, to be honest, is to be able to tell my staff and my partners that actually you're not alone in this. People are beginning to talk about this. And, sometimes when you are run down, our own very patients, the people that we are meant to serve, can seem the inverted commas enemy, which we know that is the system. So my take-home message, the bottom line is really, think of the 95 good consultations that you have at the end of the day, rather than the 3 or 4 that can sometimes ruin the whole day or the whole week.
Thank you, Amir. So I've got 2 more points. I'm going to take Lisa and then Zach. Final word from you. So Lisa, please.
I'm Lisa Phillip. I'm one of the GPs on governing body. I think for me, the take home is that general practice is so resilient, and we are coping with everything despite everything that's happening. And I feel like this is a forum for us to share learning. I think Marion alluded to this earlier, using things like Accurix. If someone has something that they're doing that works, just sharing that with each other, because we're all sort of fighting the same battles.
Thank you. And Zach, please. And we've got you on mute, Zach.
I just said I didn't introduce myself, then I muted myself. So I'm Zach Mcmurray, Medical Director at the CCG. I think it's to try and stick to the positives if we can. So, we have high quality healthcare across Sheffield, general practice, high quality, good or better, CQC wise, as far as our practices are concerned. We're not perfect, but I think we're in a really good position. It's almost like a plea. I mean, I'm probably getting to the last, well, I'm potentially getting to the last 5 years of my career, 3 to 5 years. I'd love to be getting into the last 10 years of my career. But if I could feel that actually I'm not having to fight the system to do as much, to do the best thing for my patients, it's never felt as much in 30 years that I'm having to do the right thing in spite of the system. And I'd really like to see a system that moves to be much more supportive and encouraging the old guys like myself maybe to do a little bit longer and stay in the system a bit longer. I think that'd be really helpful. I think dwelling in the positives, I still enjoy it. I still get a huge amount of response from the patients. The vast majority of patients are very happy with the service they get. And that's the bit that sort of buoys you up. I think we could do more to try and explain what we're doing and why we're changing and get that sort of communication message across and maybe get some more support with that. But we do have a system in Sheffield that is joined together really well and is very supportive. And it is still a great place to work. I'd love to see that move away from a fix people who are ill service to stop people getting ill service, because that's got to be the future. If the NHS is going to survive, that has got to be the future approach. And again, it feels as if we're moving in a direction away from that with the obsession about just treating illness. So it's the conversations we've had about that shift in resources around the preventative side and working with the population to help them keep well. But I come away from it feeling depressed and a little bit down, but optimistic. I'd like to be in a better position as we approach winter. But like you say, we all are very resilient. We're innovative. I think we will hold the system together over the winter period. It would be helpful if the system above facilitated that rather than get in the way of it and make it more difficult. So that I think as a plea is just, I'd like to get a reconnection with the national system so that it does feel as if we're much more in it together rather than, probably a system beating people up that are doing their best. I think that's what I'd like to see.
Thank you, Zach. Okay, I'm going to bring the meeting to a close now. So that was our final governing body in public for 2020. Our next public meeting will be on Thursday, the 13th of January, 2022 at 2 o'clock. And as always, we'll share details of that on our website. So thank you.